Let's turn our attention briefly to TOR inhibition in the first-line setting for metastatic patients. Dr. Pal, do you use temsirolimus? Do you use everolimus? You've talked about record 3. We know about the New England Journal article by Gary Hudis about temsirolimus. When you're deciding to use a TOR inhibitor in the frontline setting, what's the agent that you use? How do you approach it? And how do you follow those patients?
It's a great question. I think that having trained under you, I tend to be fairly data-driven, just as you are. So in the frontline setting, I can't make an argument for any agent for a poor-risk patient other than temsirolimus. I would suggest that substituting everolimus in that particular context doesn't necessarily make sense. We don't have high-level evidence for everolimus in that particular setting outside of the limited number of patients that were treated in the record 3 trial. So I would suggest that everolimus has a place, but only after failure of VEGF-directed therapy.
So you're still using everolimus in the second-line setting, which we'll talk about in a few moments.
Yeah.
Let's just close the loop, Dr. George. Hyung Kim, when he was at Roswell Park, did a neoadjuvant study in kidney cancer. Is there a role for neoadjuvant targeted therapy in the metastatic setting, absent a clinical trial? Is there anything to be accomplished so that our colleagues in the community be doing that?
Right. Again, Dr. Friglin, that's a great question. So neoadjuvant, I look at it, at the word, I look at it as a purist. Neoadjuvant therapy, to me, seems a curable, potentially curable disease where we apply treatment prior to removing it surgically. So if it's locally advanced or metastatic disease, I call it pre-surgical therapy instead of neoadjuvant. So I distinguish between that. So definitely there is a role in, we don't have an established data, any established data in this setting for using neoadjuvant therapy. But the goals of a trial which could be designed are potentially including, tumor shrinkage or making a radical surgery into a partial, getting away with the getting away with the nephron sparing approaches. So those are things one could achieve. And again, my philosophical difference here in kidney cancer is that none of these drugs can cure kidney cancer. So in that setting, elimination of the disease is really hard by using these drugs. So, shrinking the tumor down, potentially making the surgery easier. And there is some data that sparing the nephrons might preserve the kidney function and might make them live longer, or they may be able to receive other treatments based on kidney function in future as well. So those are goals that could be teased out from such a trial.
So I see those as pretty theoretical.
Right.
In a year, how many patients do you actually treat neoadjuvantly or pre-surgically?
I don't treat any.
And I think that's important that we put that out there. So there's a lot of theoretical reasons why it might be reasonable, theoretical reasons why it could be in an individual case. But Dr. Pal, I'd ask you, I can tell you that in my own practice, the opportunities for pre-surgical or neoadjuvant therapy outside of a clinical trial approach 0. Mm-hmm. Dr. Pal, in your practice?
I completely agree. I think that neoadjuvant therapy currently is in the domain of research and should be explored in the context only of studies.
So let's